Good day, everyone. Quick question. Have you ever heard about contact dermatitis? Where did it came from? How do you prevent it? Today, we're going to talk all about contact dermatitis, its description, etiology, pathophysiology, diagnostic tests, manifestations, as well as its interventions. So, listen close and I hope you learn a lot.
Contact dermatitis is an inflammatory reaction of the skin due to contact with exogenous substance. Exogenous substances are caused or produced inside an organism or a cell. Contact dermatitis has two basic types: the irritant contact dermatitis and allergic contact dermatitis. Irritant contact dermatitis is an inflammatory response of the skin to direct chemical damage that releases mediators. While on the other side, allergic dermatitis is a delayed type 4 hypersensitivity reaction to exogenous contact. 80% of contact dermatitis is irritant type and 20% is allergic type. It is mostly caused by excessive exposure or additive effects of irritants such as chemical substances or soaps.
Allergic contact dermatitis. It results from contact of the skin and allergenic substances. Allergenic substances like soaps, detergents, metals, cosmetics, and even plants. It has a sensitization period of 10 to 14 days.
Irritant contact dermatitis result from contact with a substance that chemically or physically damage the skin or a non-immunologic basis occurs after the first exposure to irritant or repeat exposure to irritant or repeated exposure to milder irritants over an expanded of time. This painful rash tend to come on quickly in response to an irritating substance. Common irritants include detergents, soap, cleaners, and acid.
For the pathophysiology of allergic contact dermatitis, can either be systemic or airborne. Systemic, in which can be exposed to an allergen in an individual with prior ACD. Airborne, if it has contact with airborne allergens in exposed body sites, and it will be very pruritic. After being exposed to allergens such as cosmetics, fragrances, personal care, topicals, occupational hapten, metals, jewelry, antiseptics, and plants, it will trigger the antigens to penetrate the epidermis and activate Langerhans cells, which travel to regional lymph nodes and activate T cells. This is called sensitization phase. After that, it will re-expose the offending haptens that may lead to hypersensitivity reaction, and the sensitized T cells will circulate in the blood and arrive at skin sites where antigen is present. This is called elicitation phase. After this phase, mast cells, eosinophils, CD4, CD8 T cells, and inflammatory cytokines will increase. The increase of mast cells will cause the release of leukotrienes, thus fighting the antigens, and will cause fever. Fever is only present in severe allergic contact dermatitis. The increase in CD8 T cells will cause keratinocyte apoptosis, or the loss of intracellular adhesions. Keratinocyte is also called the major cell of the epidermis, or the main cell of the epidermis, and apoptosis is also called the process of cell death. Okay, so after that, it will occur or manifest the spongiosis. Spongiosis is a rounding of keratinocytes and widening of intercellular spaces, resulting in a sponge-like appearance of the epidermis that can lead to formation of small intraepidermal vesicles. Dilation of local microvasculature will also occur because of the increase of mast cells, eosinophils, CD4 and CD8 T cells, and inflammatory cytokines that will lead to erythema. The increase of inflammatory cytokines stimulate the local nociceptors and will manifest burning sensations as well as pruritus or itching. Once the vesicles, erythema, burning sensation, and itchiness is present, it will likely lead to scaling, lichenification or the epidermal thickening, as well as the exoration. Exoration is also called as dermatillomania or the skin picking disorder, and where you cannot stop picking at your skin. These three are the chronic findings of allergic contact dermatitis. That is all for the pathophysiology of irritant contact dermatitis. There are several irritant agents such as abrasives, cleaning solutions, oxidatives and reducing agents, dust, soils, and water. And some common occupational exposures such as housekeeping, cleaning, catering, medical or dental, and constructions. There are also risk factors related to this, such as atopy, fair skin, low temperature, and low humidity. Acute exposures to these irritant agents, common occupational exposures, and risk factors may cause direct cytotoxic damage to the keratinocytes and increase neutrophils and cytokine release. It also may affect the skin reaction in localized and proportional to irritant concentration and exposure to time. After the keratinocytes receive direct cytotoxic damage and increases the neutrophils and the cytokine release, it may lead to the perivascular inflammation and vascular dilation that will lead to erythema. After the epidermis have received a direct cytotoxic damage, it may lead to spongiosis, or the rounding of keratinocytes and widening of intracellular spaces, resulting in a sponge-like appearance of the epidermis that can lead to formation of small intraepidermal vesicles that may lead to erosions and crusting. And after that, the shedding of crust or scaling will lead to necrosis. After necrosis or shedding of necrotic tissues, it will cause poor circulation and will lead to ulceration. When the neutrophils and cytokine release increases, as well as skin reaction is localized and proportional to the irritant concentration, it will stimulate the local nociceptors and will cause burning or stinging, as well as itching sensations that may lead to lichenification or the thickening of the epidermal layers. And once you have a repeated or chronic exposure to such irritant agents, or you have a common occupational exposures or risk factors that is related to irritant contact dermatitis, it can cause damage to the cell membranes, disrupt skin barriers, protein denaturation, as well as cellular toxicity that will lead to penetration of offending agents into the skin, elicits chronic non-specific inflammatory response that will stimulate the keratinocyte proliferation and then the epidermal thickening, as well as the rapid turnover of stratum corneum that may lead to hyperkeratosis as well as fissure and crusting, thus the manifestation of pain. And that is all for the pathophysiology of irritant contact dermatitis.
Assessment and diagnostic findings. Determining allergens responsible requires a history, physical examination, and patch testing. Assessment includes the date of onset, the causes, the location of lesions, distribution of dermatitis, absence of other etiologies, and the history of exposure aid in determining the condition. The best way to test for the reaction to allergens is by patch testing. We will further discuss about patch testing later. We have here the table that shows two types of reaction, which are allergic reaction and irritant reaction in contact dermatitis.
The first type of reaction is allergic contact dermatitis. This results from contact of skin and allergenic substance that has a sensitization period of 10 to 14 days. The clinical presentation of an allergic type is vasodilation and perivascular that infiltrates the dermis intracellular edema. This is usually seen on dorsal aspect of hand. For the diagnostic testing, patch testing is used. It is contraindicated in acute and widespread dermatitis. During a patch test, tiny amounts of known allergens are applied to your skin. It is done by putting small amounts of different substances that will be placed on your skin under a sticky coating. After 2 to 3 days, your healthcare provider checks for a skin reaction under the patches. Your healthcare provider may be able to diagnose contact dermatitis by talking to you about your signs and symptoms. Patch testing and environmental history of exposure to contact allergens are required to verify the diagnosis. Patch testing is the standard test for identification of culprit allergens in persons with allergic contact dermatitis. The patch test most commonly used is the thin layer rapid use epicutaneous test or the TRUE test. Again, thin layer rapid use epicutaneous. It is indicated for use as an aid in the diagnosis of allergic contact dermatitis in persons 6 years of age and older whose history suggests sensitivity to one or more of the 35 allergens and allergen mixes included on the TRUE test.
Second type of reaction is the irritant contact dermatitis. This is a non-allergic skin reaction that occurs when the irritant damages your skin's outer protective layer. It is a result from contact that chemically or physically damage the skin. Most common irritants include soaps and detergent. This occurs after repeated exposures. Milder irritants over an extended time within a few hours or days of exposure to an irritant or allergen. Clinical presentation includes dryness that lasts for days to months. Common areas that affect are the hands and the feet, but it can also occur on the face or elsewhere on the body. It causes the skin to become itchy, blistered, dry, and cracked. Lighter skin can become red, and darker skin can become dark brown, purple, or gray. For diagnostic testing, this includes the clinical picture on the appropriate negative test.
Symptoms of acute dermatitis include itching, or the burning sensation arising from the irritation of the skin cells or nerve cells associated with the skin, burning, erythema, or the redness of the skin, skin lesions such as the vesicles or the bullae, and oozing sensations. The reaction is limited to the site of contact.
Chronic contact dermatitis symptoms can include scaling, lichenification, thickening of the skin, and pigmentary changes. So scaling is when the skin's outermost layer forms large, dry, scale-like flakes, while lichenification is a secondary skin lesion that is characterized by hyperpigmentation, thickening of the skin, and exaggerated skin lines. Secondary invasion by bacteria may develop in skin that is abraded by rubbing or scratching. Usually, there are no systemic symptoms unless the eruption is widespread. Contact dermatitis can cause an infection if you scratch the affected area frequently, leading it to become wet and oozing. This provides an ideal environment for bacteria or fungi to develop and may result in an infection.
These are the treatments for the two types of contact dermatitis. The first one is for allergic contact dermatitis, and the treatments are avoidance of offending material aluminum acetate, such as boro solution and the Marlboro powder, and also avoid cool water compress. Aluminum acetate is a special topical preparation that contains the element aluminum. If you ever had a rash, insect bite, or other skin irritation, you may have used aluminum acetate to reduce the itching and irritation. While it has several uses for topical skin irritation, aluminum acetate itself can sometimes cause allergic skin reactions. Some people may find they're hypersensitive or slightly allergic to aluminum acetate. The possible effects of aluminum acetate includes skin dryness, irritation, and inflammation, which may develop a rash called allergic contact dermatitis. The next treatment is to administer systemic corticosteroids such as prednisone for 7 to 10 days. Prednisone works by reducing swelling and redness and by changing the way the immune system works. Next is topical corticosteroids such as clobetasone and hydrocortisone skin cream for mild cases. Lastly, oral antihistamines such as cetirizine and loratadine to relieve pruritus. For the treatment of irritant contact dermatitis, these are the following treatments: identification and removal of source of irritation, application of hydrophilic cream to soothe and protect. This medication is used as a moisturizer to treat or prevent dry, rough, scaly, itchy skin, and minor skin irritations. We could also use petrolatum. Petrolatum is a mineral oil made from petroleum. Petrolatum topical for skin is used to help protect minor cuts, scrapes, burns, or eczema. And lastly, antibiotics for infection and oral antihistamine for pruritus. In medical and nursing management, the objectives are relief from pruritus, lubrication of skin, reducing of inflammation, and prevention of secondary inflammation. Contact dermatitis can be treated with moisturizer and topical corticosteroids. But if topical treatment is ineffective, systemic immunosuppressants are also prescribed. The following are common in medical and nursing management. First, avoid exposure to skin irritants such as soap, detergents, fabric softeners, diaper wipes, and powder. Avoid excessive bathing and washing of affected areas. However, bathing water should be tepid, and the skin should be lubricated immediately after the bath. Intermittently apply cool, wet compresses to soothe the skin and alleviate itching. Pat skin dries between cooling treatments. Administer oral antihistamines and topical corticosteroids as prescribed. However, corticosteroids are applied thinly and rub into the area thoroughly. Administer medications as prescribed. Administer prescribed oral antibiotics if secondary infections occur. Provide or minimize scratching. Keep your nails short. Eliminate conditions that increases itching. Instruct patient or significant others to wash clothing in a mild detergent and rinse thoroughly. Instruct patient or significant others about measures to prevent skin infections. Instruct patient or significant others to monitor lesions for signs of infection and seek immediate medical intervention if such symptoms are noted.
For our summary, contact dermatitis is an inflammatory reaction of the skin. It is caused by excessive exposure to irritants such as soap and cosmetics. Contact dermatitis may be treated with moisturizer and topical corticosteroids. Systemic immunosuppressants may also be prescribed if topical treatments is ineffective.
For determining the allergens, we should obtain the history, perform physical examination, and do patch testing.
Patch testing is the best way to test for allergic reactions to allergens. It is the standard test for identification of culprit allergens in person with allergic contact dermatitis. It is done by putting small amounts of different substances that will be placed on your skin under a sticky coating.
For the assessments, it includes date of onset, the causes, the location of lesions, the distribution of dermatitis, and the history of exposure. We have two types of contact dermatitis. First is the irritant contact dermatitis and the allergic contact dermatitis. 80% of contact dermatitis is irritant, which results from repeated exposure to irritants or substances that chemically and physically damages the skin. For the clinical presentation, common areas that affect are the hands and feet, but it can also occur on the face or elsewhere in the body. It causes the skin to become itchy, blistered, dry, and cracked. Lighter skin can become red, and darker skin can become dark brown or purple or gray. For the treatment, first is the identification and removal of source of irritation, application of hydrophilic cream or petrolatum to soothe and protect, then antibiotics for infections, and oral antihistamine for pruritus. For the second type, 20% of contact dermatitis is allergic, which results from contact of skin and allergenic substances. It also has sensitization period for 10 to 14 days. Vasodilation and perivascular infiltrates on the dermis, intracellular edema are the clinical presentation. For the treatment, first is the avoidance of offending material, aluminum acetate, which is the boro solution, domoboro powder, or cool water compress. We also have systemic corticosteroids or the prednisone. This is for 7 to 10 days. Then, the topical corticosteroids for mild cases and oral antihistamines to relieve pruritus.
And that is all for our presentation. Thank you for listening.